Hi, and welcome to the Isaac Newton Institute podcast with me, Kira Dangerfield. I'm the Development and Communications Coordinator here at INI, and for those of you who listen to our podcast series on a regular basis, you may notice that I am not the usual person who introduces and presents the podcast. That's usually done by our communications manager, Dan Aspel, who has been away on shared parental leave. And so while he's been away, I've picked up his baton and recorded a few episodes around the mathematics of COVID-19, which is in relation to our current programme on infectious dynamics of pandemics. As with everything at the moment, these episodes were recorded during lockdown, so apologies if the sound quality is not up to what it usually is, and please bear with us during this process as we try and learn all about recording from home. So in this first episode, I speak to Dr Kit Yates, all about sort of going into a bit more detail about the actual mathematical methods that are being used to model the COVID-19 pandemic, and that are ultimately feeding into policy and things you hear on the news. So I hope you enjoy this episode and let us know what you think. Hi, and I'd like to welcome Kit Yates to the podcast today. Hi, Kit.
Hi.
So Kit is a senior lecturer in the Department of Maths at the University of Bath. He is primarily a mathematical biologist, and his work uses mathematical models to gain understanding of biological systems, including embryonic dynamics, eggshell patterning, and locus formings. He also recently wrote a popular science book called The Maths of Life and Death, which explores the vital role maths plays in our lives. In particular, he has a whole chapter devoted to epidemic models, so very relevant at the moment, and I highly recommend the book. I read it on maternity leave and it's very accessible. So welcome, Kit. Thank you very much for joining me today.
Absolute pleasure.
I wanted to discuss with you a little bit more about the maths behind the pandemic at the moment, and I think it's been featuring very heavily in the news about how the models have been informing scientific policy. And so I wanted to talk to you a little bit about, what is the maths behind these models. Models that have been informing policy regarding this COVID-19 pandemic at the moment have used what are called compartmental-based models. So can you just briefly explain what a compartmental model is, and in particular the SEIR model?
Absolutely. So it's a strange time to be a mathematical biologist at the moment. Our subject is front and foremost of all the news every day. So it's a good time to be doing communication around the subject. In terms of the sort of basics of the epidemiological modelling that we teach undergraduates, we use these compartmental models, as you mentioned. We break the population down into different groups. The most basic model we use is actually called the SIR model. So those three letters stand for susceptible, infected, and removed. So susceptible people are people who have not had the disease yet. Infected people are people who have the disease and are infectious and can pass it on. And removed it's a sort of euphemistic term for people who have either recovered or, unfortunately, people who've died, but either way are no longer passing on the disease. And so the way the model works is that you start off with everyone being susceptible, and you introduce an infected person, maybe someone who has got off a plane and they're infected, and they can then infect susceptible people. Those susceptible people become infected. They can then infect more susceptible people, and eventually the infected people start to recover or unfortunately die and move into this removed class. So that's the most basic model we use, and it's based on a lot of assumptions. We usually think of it as being purely deterministic in the most basic version. So we write down a system of ordinary differential equations. We assume that everyone can see everyone else. So the population is well mixed. It's homogeneous. So there's no differences in the way people react to the disease. Clearly, these assumptions are not entirely realistic. And upon infection, we assume that susceptible people immediately become infectious. Now, this is probably the first assumption that we would go and relax in these models, and we would create what you mentioned. We'd create the SEIR model. So we introduce another category of people. The E stands for exposed. So instead of going to immediately into the I category, people who are infectious, what first happens is when a susceptible person bumps into an infected person, that susceptible person might get the disease, and they are then moved into the exposed category, but they're maybe not yet infectious, because we know there is a period of time after getting the disease before the virus jumps up to large levels of particles in your body, before you can start to pass on the disease. And that's around 4 to 5 days in the case of COVID-19. So that's the most basic model. We assume there's no immigration or emigration in the most basic version. The population size is constant, and we assume that the outbreak occurs over a relatively short period of time, so we don't really need to think about births or deaths. But all of these assumptions are things that can be relaxed in order to make the model more realistic.
So I just want to, so I guess one thing when you talk about the exposed class, with COVID-19, as far as I understand, it's quite important to include that in, because it adds in this sort of lag time when you're talking about control strategies and, you know, looking at when numbers of deaths are going to peak and when they need to, say, close schools. They need to kind of have that 5-day lag period from when you might get infected to when you are actually infectious and able to pass the infection on to others. Is that sort of...
Yeah, it's exactly right. It's really important. And actually, I think people think of mathematical modelling of disease as just being a way of predicting into the future about what's going to happen. But actually, mathematical models have helped us to find out how long that infectious period is, and also to suggest this quarantining rule that we have. So if you have symptoms, you quarantine for 7 days, but then you also, people in your household have to isolate for 14 days, because there may be a period, if they get the disease at the end of your infectious period, where they're not showing symptoms. There's also this asymptomatic period where they may have the disease. So you have to make sure that they isolate in case they have symptoms but have not yet developed, have the disease but have not yet developed symptoms. It's not always clear. So building this exposed category in, there's also the possibility of building in what's called a carrier class. So people who have the disease and can pass it on but are asymptomatic. And we know that with COVID, there's a period where even people who do develop symptoms can be asymptomatic before and still pass the disease on. But there are also people who are passing the disease on and have very mild or no symptoms, so that this carrier class might also be an important thing to build into these models.
But the problem sometimes with the asymptomatic classes, as far as I understand, is that that they don't really know what proportion of people are asymptomatic. So there's like a trade-off when they're building, adding in compartments into the model in terms of making sure it's more realistic, but also making sure that you have some way of determining what these parameters are, so you don't end up with just a huge model with hundreds of parameters that you don't know what they are and they're unidentifiable. So
absolutely, the more realistic that you make the model, the more data you need in order to get parameters or to parameterize the model. And actually, certainly at the start of an epidemic, data is usually relatively scarce on the ground. And so trying to get data for how long people are infectious for, how long they might be asymptomatic for, what proportion of people are asymptomatic is really difficult. And actually, really the only way to access those sorts of things is to do randomized controlled trials, where you actually test a random proportion of the population, not just people who are developing symptoms. And we're not really doing that at the moment. We're largely just testing people who are going to hospital because they're presenting with symptoms. We're trying to roll out tests a bit more widely, but really we need to do randomized testing in order to find out what proportion of the population have had the disease, what proportion of people have it at the current time, and do they show symptoms, so we can work out the proportion of people who are symptomatic versus asymptomatic. So yeah, getting data for these big models is really difficult. So in some senses, having a more simple model has something to be said for it.
Yeah, you can still gain a lot of insight or some understanding of what's going on just from a simple model.
Yeah, absolutely. Even from the most basic SIR models, which are deterministic, we just have 3 ordinary differential equations. They can give you insight into, what you expect to happen. They can suggest control measures that you might want to implement, even based on those relatively simple models.
Great. So I want to just take a step back, I guess, a bit, and talk about so we have these deterministic differential equations that describe how the numbers are changing in each of these different classes, which is based on a type where you are in the infection. And so how do these models actually capture the transmission process itself? So the point at which I say will pass the infection on to somebody else. How do they capture that mathematically?
Yeah, so when we write down these ordinary differential equations, usually the left-hand side of the ordinary differential equation will be the rate of change of susceptible individuals, or the rate of change of infected individuals. And the right-hand side will be some function of the number of infected individuals, the number of susceptible individuals, or other people in different classes if you have more classes in your model. So usually the number of susceptibles will decrease, at least initially, because susceptible people are becoming infected. And we have an incidence rate. So that's this function on the right-hand side, which tells you how susceptibles and infected bump into each other and how susceptible people become infected. So usually that's S, the number of susceptibles, times something which we often write as lambda, which is called the force of infection. So the force of infection is often broken down into three parts. So firstly, the proportion of individuals who are currently infected. Multiply that by the rate of contact that people have with other individuals. So obviously the more contact people have, the faster this disease is going to spread between people. And then also we need to multiply that by the probability of transmission. So again, the bigger the probability, the easier it is for the disease to transmit per contact, the more likely this disease is going to spread. And sorry, go on.
Oh, no, sorry. I was just going to say that, and in that probability of infection between contacts is usually not known, and that's often the thing they have to estimate, right? Because it's seen as unethical to run an experiment where you knowingly infect an individual. Is that
absolutely? Yeah. So getting a handle on this transmission probability is something it's really hard to get hold of. The other things are easier, although that said, even with the contact rate, there are different ways of modeling that. So there are sort of two types of transmission, or two main types of transmission that we might consider. One of those is density dependent transmission. So your contact rate depends on the number of individuals in the population. So that's more appropriate for airborne diseases. And the reason it's called density dependent is it basically means that the higher the density is, the more transmissions you're going to have. So if you think about a city like London, which has a high population density, then there's going to be more frequent meetings between susceptible individual people, and they're going to be able to pass on the disease more often because of those more frequent meetings. The other type of transmission is called frequency-dependent transmission. So this contact rate is just considered to be a constant. And this is more appropriate for things like sexually transmitted diseases, because for those diseases, it doesn't really matter how many people there are in the population, because you can only have sex with so many of them, if you like. It doesn't. The number of people you have sex with in London doesn't increase dramatically because the population of London is much more dense. So those are more appropriate for sort of sexually transmitted diseases, and usually for airborne diseases like COVID, we would assume density dependent contact rate.
That's actually, that's a very important point you make there about these differences. I think for novices coming into epidemiological model, that's a very a subtlety that's often passed over, but it can make a really big difference.
Yeah, absolutely. I think especially if you're thinking about the differences between an airborne disease and a sexually transmitted disease, with an airborne disease, anyone can pass it on to anyone else, but with a sexually transmitted disease, you need to really take into account the structure of sexual relationships. So some of those will be homosexual, some of them will be heterosexual, and those really make a difference. And so, for example, when trying to understand who we should vaccinate with human papillomavirus, we really need to take into account the fact that there are or different types of transmission for sexually transmitted disease like HPV.
But touching on that, for sexually transmitted diseases, obviously having that the sexual network is very important. But it can also be important for airborne diseases, right? So like the way we interact socially is not. So I don't have an equal probability of meeting and contacting everybody in the whole of where I live in Cambridge. There is very much a structure to our contacts, right? And there have been studies showing about how, hopefully I'm right in saying this, about how, as children tend to interact more with you interact with people tendingly more your age, and then but people who say are in their 30s and have children then also have these interactions with younger children from their families, and so this contact structure is also very important to capture in trying to model an airborne disease.
Absolutely, yeah, you're absolutely right. So yeah, the models that we've described so far, assuming sort of well mixed populations, everyone sees everyone else, and everyone is almost the same as each other, and that's clearly not the case. So the ways that we can start to relax those assumptions are, firstly, as you mentioned, by building in some sort of network structure to say that not everyone meets up with the same number of people. There are some people who meet up with a lot of people, and there are some people who meet up with relatively fewer people. Part of that, as you mentioned, might be to do with the age structure. So we can find these matrices of rates of contact between individuals in different age groups. And as you mentioned, people tend to hang around with people of their own age. That's the sort of the largest entries in these matrices. But of course, there are sort of off diagonal entries, if you like, for parents and their children, teachers as well, contact with children as well. There's also further off diagonal entries for grandparents with their grandchildren. So taking into account those structures can be really important for understanding the spread of the disease. In particular with flu, we think that a lot of transmission happens in school, although that's not actually what's happening, we think, with COVID-19. There's also age-related severity of the disease, so it's important to break the models down into age structures, because actually different aged people have different reactions to this disease, different case fatality rates or infection fatality rates, the proportion of people who will die as a result of having the disease. So those are sort of really important assumptions to make. Some of the important models that are being used to inform the government, the models from Imperial College at the moment, they're actually not really using these ordinary differential equation-based models. They're using agent-based models where people are modelled as individuals. They also have things like household structure and work structure in there. So people live in these models, they live in a house, and they'll go back to their house at the end of the day and potentially transmit with people in their household, but then they'll go off to work the next day and they might transmit with people in work, or they might do some things outside of work, sports or whatever it is, and there might be transmission in the community as well. So these models that they've been using are thousands of lines of computer code, and they are incredibly complicated, but as we've already brushed on, actually parameterizing these models can be extremely difficult. The other thing to say is that the models we're talking about so far we've been talking about deterministic models, so models which don't have noise in them. But of course, understanding randomness can be really important for this. People don't have a constant rate of infection, constant probability of infecting other people. People's infectious period isn't just a 5-day period. That might be the average, but actually people might be infectious for 10 days, some people might be infectious for 3 days. And so building that stochasticity in can be really important to try to represent the disease appropriately in these sorts of models.
Yeah, and sort of what you touched on at the end there, I think is an important point, because it's also a way that they're capturing the uncertainty in what they're in their model predictions, right? So they know their models are just they're not reality in simulation. They are a sort of a simplified version. And so when they're informing the government, they're not sort of saying, this is what you do and this will be the outcome. It's more, this, if you do this, there is this probability that this is going to happen, or we think this will be the most likely scenario, but there's not. So they are incorporating uncertainty into what they're doing.
Absolutely, yeah. So they're really thinking about, what the parameter values that they're putting into these models, what are the most extreme value it can take, what is the extreme at the other end, and thinking about what's the worst case scenario and what's the best case scenario. And actually when they put in the effects of interventions into the model, which is effectively what we're trying to do, we're trying to predict what will happen when we intervene and we shut down a school or we make people socially distance. Again, the effects of those measures are not certain. So in Neil Ferguson's paper from Imperial College, they say things like, if you're isolating, then we're going to assume that people are staying at home for 7 days. They're reducing their non-household contacts by 75%, and we assume that 70% of the households will comply with this policy. But those figures are sort of pessimistic, but they're almost made up off the bat to see what will happen in these certain situations, because it's really not clear what proportion of people are adhering to all these policies. So it's a really difficult job, and the best we can do is to be upfront and honest about the fact that these models and their parameters do have uncertainty in them, and that we're not just reporting a headline figure which might get reported in the newspaper, but we're actually saying, well, this is the worst case scenario, this is the best case scenario, and we need to plan for the worst case scenario potentially.
Yeah, and so I guess just touching on that imperial, the model, because I don't know whether some people seem to think that it hasn't. I've just seen some comments from mathematicians that they feel that uncertainty hasn't been incorporated. I appreciate you aren't actually an author on the imperial model, so this is more just from having read the paper and things. So they do, from when I remember looking at it, they do have just a sort of a single line. They don't kind of show error bars or give uncertainty in their measurements, and they don't have a section where they specifically talk about how they've incorporated uncertainty or doing scenario analysis, for example, looking at if they had different compliance rates, what happens. I don't know, have you seen anything like that, maybe in like looking in a bit more depth at the paper?
Certainly in that original paper, the expression of the uncertainty is relatively limited, although it should be said that they do run the paper, the model, with different reproduction numbers. So we haven't really talked about the reproduction number, but in essence, it tells you the number of infections that a single infected person will pass the disease onto. And at the start of the disease, it's called the basic reproduction number, and it tells you how many people a single infected individual passed the disease onto in a purely entirely susceptible population, so the first person that gets off the plane. And as the disease progresses, it becomes called the effective reproduction number, or just the reproduction number. So they do have values for this reproduction number in their model, and the sort of average, or the middle value that they use, if you like, is 2.4 for this reproduction number, but they do look at different values of the reproduction number. So they do, in some senses, incorporate uncertainty in that reproduction number, which captures a large amount of the information in any model, this reproduction number. So it's not fair to say that they completely don't consider uncertainty in their model, but certainly they do it in a very sort of broad brush way, I would say.
But actually, you touching on that I think that is an important point to make, because R0 is often the thing you're probably most uncertain about, isn't it? Would you say maybe right? Like it's kind of, and it captures, like you say, an awful lot of things. So by looking at just that one uncertainty, you are doing quite a lot, really.
Exactly. So, I mean, in terms of like you're thinking about the basic SIR model that we started talking about, the reproduction number almost tells you everything you need to know about that disease model. It's an amalgam of different parameters. It takes into account the transmissibility of the disease, the infection duration, and the number of susceptible individuals you have in the population at that particular time. So it takes the parameters of the model and it does it builds them into what's called a single non-dimensional parameter, so it doesn't have units anymore. And it basically, the bigger it is, the worse it is for the disease. So trying to at least consider the uncertainty in this sort of meta parameter, if you like, this basic reproduction number, or this reproduction number, is at least something that is important to do. And it should be said that the reproduction number is really important for suggesting what sort of interventions will work and which ones won't.
And I guess as well how strong your intervention needs to be, right, so that you make sure this R0 is going below 1.
Exactly. So trying to bring the reproduction number below 1 so that on average each new infection passes to fewer than one other person is really important. And I guess we can say something about what measures it suggests. So firstly, quarantining people. So if you isolate people who may or may not be infected, then that reduces your transmission rate, as potentially infected people can't spread, but it also reduces the effective number of susceptible people in the population. So everyone's staying at home at the moment under lockdown. We're reducing the potential for infected people to bump into susceptible people. We're reducing the effective number of susceptible people in the population. Isolating people who do have the disease, well, that effectively, in the context of the SIR model, that takes them straight from being infected into the removed class, so that effectively increases their rate of recovery, if you like, or decreases their infection duration, so that decreases the reproduction number as well. Things like social distancing also reduce transmissibility, so the further you're standing away from someone, the less likely it is that you're going to be breathing in the viral particles that they might be shedding if they're infected. And things like hand washing, even, this was the big message that was being pushed at the start of the outbreak. hand washing can dramatically reduce the reproduction number, and some studies have showed that you can reduce the reproduction number by as much as 3/4 by simple hand washing, which can have a really, really huge effect. So all of those things are really sensible. And then, of course, vaccination. If we could develop a vaccine, then I know this is a long way away, but it effectively takes people directly from being susceptible to being immune to the disease. So it reduces the number of susceptible people and reduces the reproduction number and helps to wipe out a disease. So that's, I guess, the end goal of this, but it's a long way off at the moment.
And actually, since you've touched sort of on vaccination, just kind of a slightly tangential question, but that I think has been coming up quite a lot in the news, is this idea of herd immunity. And I saw quite a few epidemiologists get quite annoyed that herd immunity was being bandied around as if it was a policy choice.
Right.
But saying that it's not a policy choice, it is essentially a consequence of the fact that we don't have currently a vaccine. And so they're kind of, it's an outcome of what will potentially happen if the disease is just allowed to sort of spread.
Yeah.
So if you could just sort of briefly talk about what herd immunity is and why it's actually just this consequence rather than a policy in and of itself.
Absolutely. So herd immunity is quite a mathematical idea. It's the idea that we can eradicate a disease without all of the individuals necessarily being immune to the disease. If we can get a sufficiently high proportion of the susceptible population to be immune, then we can deny the disease the susceptible infected contacts it needs to pass on. Now, that is the ideal way to do that is through vaccination. You give everyone a vaccination, and if you can vaccinate enough people, then you can effectively wipe out the disease, and you don't have to vaccinate everyone. So in particular, people who have frail immune systems, or the elderly, people who wouldn't tolerate a vaccination very well, to people who are too young to have the vaccination, don't necessarily need to be vaccinated in order for us to wipe out the disease. Now, the other way to gain herd immunity is again for people to become immune, and the other way to do that is for people to have the disease. And so that was something that was sort of being potentially suggested by the government as a way to get out of this situation, is to let the disease go through the population and for people to gain immunity that way. And I think it was quickly realised that would have entailed a large number of unnecessary deaths, and so that was quickly backtracked upon very wisely.
And I guess, sorry, we should just point out as well that there is currently, it's not, because it's a new infection, they don't really know how much immunity, or if people even do have immunity, right? These are still big unknowns that they are trying to figure out, and how long immunity will last and all these kinds of things are just like flu. Exactly. You're not immune if you have it one year, you're not necessarily immune next year. So it's there is a lot of uncertainty around that idea.
Exactly. The World Health Organization is saying that maybe between 2 and 3% of people have had this disease, and they don't really know yet what proportion of those are infected or have effective antibodies. And they certainly don't, because we're at an early stage of this disease, we don't know how long that immunity will last and how strong it is. So actually that's a little bit worrying from the context of developing a vaccination. If we're not mounting a strong immune response to this, which is what the vaccination relies upon, how can we develop an effective vaccine? In terms of the mathematics, and going back to the basic SIR model, the reproduction number, which we've talked about and said it's really important, it can also tell you how many people you need to vaccinate, or what proportion of the population need to become immune before you get this herd immunity effect, and the disease will start to naturally wipe itself out. And so the more infectious the disease is, the higher the reproduction number, the basic reproduction number at the start of the disease, the higher the proportion of the population you need to vaccinate. So the formula is 1 minus 1 divided by R0. So if you have an R0 of 4, for example, for a disease like smallpox, then that means that the fraction of the population you have to wipe out is 1 minus 1 over 4, 1 minus a quarter, or 3/4. So you have to immunize 3/4 of the population to wipe the disease out. And when the World Health Organization wiped out smallpox back in the 1970s, they set themselves a target of 80% to account for the fact that there was going to be some ineffectiveness in the vaccine, and there was going to be some people that they ended up missing. And actually, that was the great success story of vaccination is eradicating smallpox. It's the only human disease we've ever been able to wipe out from the whole face of the earth, although we're getting close with polio. Although ironically, COVID-19 is actually making those programs to eradicate polio more difficult to implement at the moment. So we're seeing drops in vaccination, not just against polio, but against lots of other types of diseases at the moment as people stay at home and worry primarily about this disease. So herd immunity is important. It's the only way we're going to get out of this, but how we achieve herd immunity is going to be an interesting question.
Yeah, that's a very, very important point. So thank you very much. That was a great sort of whistle-stop tour of the maths behind these epidemiological models. So I guess just sort of starting to wrap up, just kind of as you're not an epidemiologist, sorry, but you are a mathematical modeler. So and in particular, you do model these biological systems. So, like, just from your opinion, what do you think some of the key challenges are that modelers are kind of facing in terms of trying to get a handle on this outbreak and control measures?
I think that perhaps trying to just get a handle on the parameters to put into your model is probably the most difficult thing. There's so much uncertainty in the data, so much uncertainty in this reproduction number. We didn't really mention it, but the reproduction number is not just this characteristic of the disease. It depends on the population in which it's spreading. So actually, some of the models have been using reproduction numbers from other countries, but they won't necessarily be perfect caricatures of what's happening in the United Kingdom or in the other countries that the models are being applied to.
And that's in part because of these differences in contact structure, right? So like
exactly.
Contact structure is very important.
Exactly. So we think that the transmissibility of the disease and probably the infection duration will be similar across different countries, but actually the way that people interact with each other, even the household structure, who people live with, is different across different countries. And so you can't just take the reproduction number from one country and apply it without thought to another country. Even just trying to characterize the basic figures to get an understanding of where we are in the infection is really difficult. So the daily figures that we get in government briefings are just how many people's deaths have been reported today, for example. But really, it's more useful to look at the date on which people died. There's also over-reporting in terms of people who've died with COVID-19, but not necessarily because of COVID-19. And we know that there's underreporting as well, because we're not catching a lot of the cases that are occurring in the community. When it comes to just understanding the number of cases that are out there, let alone the deaths, which we can be fairly sure when someone's died and when someone hasn't. But the cases, there are false positive with tests. There are people who are having mild versions of the disease who are very sensibly staying at home. We're really only testing largely at the moment people who are in our healthcare system. So getting an accurate picture of the number of cases is really difficult. And this makes things obviously really difficult for modelers, especially when you're doing this in real time and constantly having to update your figures and your models based on the data that's coming out. I think it's easy to model a pandemic, or perhaps easier to model a pandemic in hindsight, but when you're doing it in real time, I think that's a real challenge that these modelers are facing.
Yeah, and also the fact that these are highly complex models that they normally would spend, months or even years developing and honing, and they're being asked to do it in a matter of hours. Yeah,
I think as academics, we're sort of used to having time to think about things, and we will send papers for peer review, and we'll get suggestions from people and build those into our papers, and it can take years before publishing a paper, and these people are being asked to do this on a daily basis and to update their models, and they will get things wrong. Unfortunately, that's definitely going to happen, but it's about how we react to that, I think, and that we acknowledge those mistakes and that we build from them. That's the really important thing.
Yeah, transparency in what they're doing, which I think, to be fair to them, they have really tried to do with putting so much online in archives, and then there are these initiatives to try and have these rapid reviews coming out from the publishers. But I think it is an important point to make, just from having worked at Public Health England myself, and seen, like you say, the messiness of the data and the speed with which they are having to give responses to government. And I think there can be a lot of complaints about models, but I don't know what about you think, but I think sometimes they're trying to do the best they can in the situation that they have, and it's still at least providing having some kind of, rather than just one person saying, I think we should do this, there's some actual trail of where this decision came from and how it came to pass. And so some way of critiquing it as we're going along and also afterwards, so we can learn from it.
Yeah, absolutely. I think it's important that we're as transparent as possible. The modelers are transparent and putting everything they're doing out there and being as transparent as possible. I would like to see the code released. I believe Neil Ferguson's lab haven't yet released the code. That's largely because it's a bit messy and undocumented.
I think they're working with Microsoft Research. I've heard that Microsoft Research have basically taken the code and making it all neat and tidy. But yes, I think maybe going forward, this again adds this point of, when we publish papers, they should always have code attached to them, because this is based on a previous paper essentially. So if he'd had to make the code open source 10 years ago when he wrote the flu paper, he would essentially have it already there.
Yeah, that's absolutely right. I think it goes a lot to the movement towards reproducibility and replicability in academia. Putting your code online with your paper should be a standard part of publishing a paper nowadays. You shouldn't be allowed to do it without it, I think, unless there's some very good reason. If you'd had to do this before, then it might have eased the pain in terms of having to now go back and comment it and work with Microsoft to make it easily understandable. But but as we say, that there's a lot of things to think about in with these models, and we're going to make mistakes as we go along, I think.
Oh, that's great. Thank you very much for talking to me. So I have just a couple of sort of more fun wrap-up questions. So,
sure.
So first of all, if people want to find out more about you, I was going to, your Twitter handle is...
It's Kit_Yates_maths, which is a bit silly, and my website is www.kityates.com.
Okay, that's great. And I'll put links to all of these in the show notes if people want to find out more about the work Kit does, or get in contact with him. Talking of Twitter, sort of one epidemiologist or mass communicator who you would recommend people follow, who you think has been putting out some really sort of interesting and useful stuff on Twitter regarding the modelling work of COVID-19?
Yeah, I think without doubt, my go-to person on Twitter is Adam Kucharski.
Yeah, I really like. He's really good.
He's great. He's obviously reading the literature and making it easy to understand. So he's at the London School of Hygiene and Tropical Medicine. He's working on trying to understand this at the moment, but he's also a really great communicator on Twitter. Adam is probably the top person I would recommend.
I very much agree with that. He's also got a book which I've been listening to on audiobooks. Yes. Where they interestingly call it the SIR model.
Oh, really? Okay. Yeah,
he didn't read it. It was obviously read by someone else. Do you have any book recommendations for if people want to get up to speed on the mathematics behind these models?
Yeah, so in terms of the sort of interesting primers, Adam has this nice book called The Rules of Contagion, The Maths of Life and Death. My book has a nice chapter. I think in America the title is the subtitle is How to Stop an Epidemic. So those are good sort of non-mathematical primers. In terms of if you want to get up with the maths, then you could do a lot worse than sort of basic mathematical biology books, which are quite big ones. Essential Mathematical Biology by Nick Britton has a nice introduction to these sorts of models, and just Mathematical Biology by Jim Murray is sort of the classic text in our field, and it also has a nice introduction to these sorts of models. So either of those two would be good to start looking at the mathematics. Yeah,
the Jim Murray book actually was my very first introduction to disease modelling back in my second year year of maths. So it's very good just introduction to get into the mathematics rather than getting tied up with the sort of epidemiology and any sort of language barriers and things like that.
And it's quite accessible for a mathematician.
So I guess just finally, as a community, what do you think we as mathematicians can do to help support this mathematical modelling effort?
Yeah, so there is the Royal Society have put out this call for the rapid assistance for modelling pandemics. That's closed now, and certainly we at the University of Bath have put in our suggestions for what we might be able to help to do, and we're waiting to hear back from that. I think that Julia Gogg, who's at Cambridge, wrote a really nice article in Nature about what people who are modelers can do. One of the things is to, and actually the title of the article was about amplifying the signal and not the noise. So one of the big problems at the moment is that because the models that we've talked about today are relatively straightforward, I think everyone who has a quantitative training thinks that they can suddenly go and become an epidemiologist. And actually, there are hundreds of preprints flying around on the internet where people have made a contribution, and I'm not criticizing people for doing this, because people want to help out, and that's great. But actually, there's just too much stuff out there for anyone to feasibly go through and summarize. So I would say that maybe don't just go out and put a preprint on the internet that you think is important, but maybe volunteer and help to read other papers that are out there and help to try to summarize those. But the Royal Society is trying to coordinate the modelling effort for this, and we're sort of waiting on them to tell us what we need to do.
Yeah, no, I think that's an important point. It was actually her article that inspired me to write that question.
Right.
And I think, so the Royal Society have also, I think today is I forget what day it is now. We've been in lockdown so long. The 28th of April is the day we're recording this. And they put out a call to saying that they're going to try and have a coordinated effort across the different publishers to get sort of rapid reviews out. And they're asking for people to sign up to be reviewers. So if you feel you can review, that's quite an important thing you can do. Because I think that is an important point, this idea of just everyone now trying to publish something on COVID-19. Because as well, you don't want everyone sort of reinventing the wheel, as it were.
Absolutely.
And there can also be challenges. You couldn't read the some of these papers coming out from Imperial and LSHTM. They use certain language in the epidemiological community to describe things like an IBM model, but some other people may use different words like processes or stochastic simulation. They may all be the same thing, and you may not realise it. You may be just doing what's been done before. So having a coordinated effort from the maths community, I think, is really important, like you say.
Yeah, so. Absolutely. Yeah.
So thank you very much for talking to me today, Kit. Thank you very much.
That's been an absolute pleasure. Thanks.